Good evening, good evening, good evening, everyone. Thank you so much for joining. I am Samuel, and it's a pleasure to welcome you all this evening. Thank you for taking the time out to join us as the CCFP Jamaica chapter brings to you another wonderful continuing medical education seminar. Today's discussion is on cancer, mental health, and ethics. The theme being growth beyond the growth, overcoming mental, physical, emotional challenges of female cancers. As I said, it is just wonderful to have you. I now hand you over to our moderator for this evening's session, the radiant and wonderful and capable Professor Monica Aznani. Over to you.
Thank you so much, Sam. You always give me a lovely smile, even on the phone when we ever end up in a call. Thank you so much. Good evening, everyone. It's really good to be here today to interface with my colleagues, my family medicine and other colleagues. We have a wonderful lineup, even though it is end of the day, and as Sam reminded us, payday. So it's good to see such a great turnout, which means we are really wanting to hear about the expertise of our panel, the theme, growth beyond the growth, overcoming mental, physical, emotional challenges of female cancer. So we're really focusing on female cancers today, but as we as family docs tend to do, not just on the physical, but the overwhelming mental and emotional kind of challenges that a woman faces while adjusting to life with cancer. So our first presenter I would love to welcome is Maxine Cargill. Dr. Cargill is a steadfast college expert. She has been with the college contributing for decades. And she's here with us today to lead this evening with a wonderful prayer. Maxine, over to you.
Thank you very much, Monica, Dr. Aznani. Let us just quiet ourselves for a few seconds, throw off all that has been in the past up to this point and just focus on this time. Let us pray. Almighty Father God, loving, gracious, merciful God, thank you so much, Lord, for just protecting us up to this point, dear Lord. Seminar, which is of such great importance, Lord. Help us to be focused, dear God, so that we can learn and just be more equipped to help women of this nation, Lord, to become, to have a better chance of avoiding this cancer and fighting this cancer, dear Lord. I thank you for the speakers, dear Father, the presenters. I pray that they will, just be at their A game, Father, and I pray that you will allow them to just present with clarity. Dr. Frankson and Dr. Ross. I pray that you'll also be with our IT support, with Mr. Samuel Heron, because without him, their Father, we will not be able to hear anything tonight. I also pray for those who are behind the scenes and those who are wanting to join, and they'll have an opportunity to join their Father. All these things I pray in your Son's precious name. Amen.
Thank you. Thank you so much, Dr. Maxine Cargill, past president of CCFP Jamaica and one of our stalwarts. You really, really settled me with your first sentence itself, Maxine. Thank you so very much. Over to welcome us this evening, Dr. Seni Ononuju, who is the president of the CCFP Jamaica chapter. I see you have joined us, Seni. Over to you.
To all our attendees, presenters, esteemed colleagues, moderator, administrative team, IT and technical support staff, and our sponsor, MedImpact JA, a pleasant good evening. to you all. It is my distinct pleasure and honor to be once again a part of this evening's webinar on cancer, mental health and ethics, where we will examine some of the physical, mental, emotional, psychological, and ethical challenges of female cancers and hopefully assist our patients to thrive and experience growth beyond growth. Gynecological cancer is any cancer that starts in a woman's reproductive organs. There are 5 main types of gynecological cancer: cervical, ovarian, uterine, vaginal, and vulvar. This evening, we will be focusing on cancers of the cervix, ovaries, and endometrium. According to the Jamaican Cancer Registry at the University of the West Indies in Jamaica as at 2018, a total of 7,348 cancers were recorded and males accounted for 3,495 and females for 3,853. Cancer of the prostate, breast, colon, and lung and cervix uteri remain the 5 most prevalent cancers in Jamaica. In females, the leading sites are breast, colorectum, cervix uteri, corpus uteri, and stomach. Of noteworthy mention, cancers of the cervix occur in young females of reproductive age group, and if early diagnosis is not made, these cancers can lead to high morbidity and mortality. The burden of cancer can take an overwhelming toll on the physical, mental, emotional, and psychological health and well-being of cancer patients, their families, and caregivers. It becomes imperative that we understand, acknowledge, and provide medical support and empathize as much as possible to these individuals. Ethical considerations may and do arise when attending to this specific population of individuals. As frontline healthcare workers, it is imperative that we remain guided by our ethical codes while we dispense care as is deemed appropriate. As such, we have in our midst a lineup of 3 experienced speakers who will delve into these topics this evening. Consultant oncologist and gynecologist, Dr. Natalie Medley, research psychologist, Georgia Rose, an epidemiologist and bioethicist, Dr. Anthony Frankson. Doctors Medley, Frankson, and Mrs. Rose, we wholeheartedly welcome you. I also wish to acknowledge MedImpex Jamaica, our proud sponsor of this evening's webinar. I wish to seize this opportunity to acknowledge the members of the college who continue to attend and participate during these events, and all other allied healthcare workers for their attendance and participation. Thank you all for your attendance this evening. As we are well aware, the choices are many and you could have been somewhere else. Do enjoy the presentations. God's richest blessings.
Thank you so much, Dr. Onanuju. Thank you for your welcome and really setting the stage for the rest of the afternoon. And I think all or most of our speakers are here, but let's get going. Just to say that we will be having a Q&A session at the end of the 3 talks. So hold on to your questions. For those of you who might forget your questions, put them in the Q&A, and Sam will guide us how to do all of that as well. And we will go through I'm sure, a very lively discussion and questions and your comments at the end of the 3 talks. So without further ado, let us start with our first talk, which actually jumps right into the female cancers. Cancer continues to be a leading cause of death, and gynecologic cancers, I think for women in Jamaica, at least one or two of them are in the top 5 cancers for women in Jamaica. So it behooves us to really hear about them. And we are happy to welcome Dr. Natalie Medley, who is a consultant obstetrician and gynecologist and a gynecologic oncologist working at the University Hospital of the West Indies and an associate lecturer at the University of the West Indies as well. She also works privately. She attained a Bachelor of Medicine and Bachelor of Surgery MBBS degree with a distinction in ONG, what else, and honors in general surgery at the UWI in 2008. Her passion for women's health drove her to pursue a career in obstetric and gynecology, and she completed her residency in the same at UWI in 2015. She then went on to complete a fellowship in gynecologic oncology, a well-needed area, and an editorial fellowship with an international journal of gynecologic cancer. And she now serves on that same journal as early career editorial board. She has recently been accepted to the editorial board of the Obstetrician and Gynecologist, a leading peer-reviewed journal in the field. At the UWI, she's also an associate lecturer. She enjoys all those roles as she does clinical work, teaching residents and medical students, and conducting research. So all 3 arms of the work, Dr. Medley, and her research has resulted in a few publications. Despite all of that work, she does have other interests outside of work, which include music. She's on the worship team at a church. Her other passions are exercise, art, and photography, and watching movies with her son. Michael Keith was a lovely name you have there for your son, Dr. Medley. We really look forward to your presentation, and over to you.
Okay. Thank you for that warm welcome. And I also want to thank the organizers for inviting me to speak on these topics, which are very near and dear to my heart. I'll share my screen and go ahead. Okay, so as mentioned earlier, I'll be speaking with you today on cervical, ovarian, and endometrial cancers, in keeping with the theme beyond the growth, overcoming mental, physical, and emotional challenges of female cancers. So gynecologic cancers impact the biological source of women's identity and the source of her ability to reproduce. And the quality of life issues are of special concern to women with these conditions. No other group of disorders impacts a woman's perception of her body image, femininity, sexuality, and also her reproductive potential. They affect the quality of life of those affected from diagnosis, for example, women who have bleeding during and after sex with cervical cancer, during treatment and even after treatment. So let's look a bit at each of these cancers. So with endometrial cancer, for example, also known as cancer of the womb, the source of life, and the definition of womanhood for many. Cervical cancer patients are usually younger than most other gynecologic cancer patients and are oftentimes nulliparous. And the association of cervical cancer with HPV, or the human papilloma virus, and the link to multiple sexual partners can sometimes cause guilt, fear, shame, and anger in these women. And also ovarian cancer, which is a silent killer because of how late it presents, usually affects older women at a time in life when they may be retired and just looking to enjoy their life success. Furthermore, the genetic link with some of these ovarian cancers means that they can find their way into the next generation of women, causing familial repercussions and fear in other family members. Patients with gynecological cancers, we see them as our mothers, our sisters, our friends. And for us female physicians and nurses, we may even see ourselves in these patients. Cancer overall, as was mentioned, is a major societal, public health, and economic problem. Approximately 1 in 5 women and 1 in 5 men will develop cancer in a lifetime. Most people are living with the long-term effects due to improvements in treatments for cancer. And while it's a major event for all who are diagnosed, it can bring opportunity for growth. So as challenging as the experience is, it has led many survivors to make important changes in their lives. They may take time to appreciate each new day. They may have learned how to better care for themselves and value how others care for them. They may even become advocates to help cancer research, treatment, and care. How can we best help our patients navigate life after a cancer diagnosis? So let's talk a bit more about each of these conditions, starting with endometrial cancer. So it's the second most common gynecological cancer. Data here locally shows that we have about 14.8 per 100,000 cases in our women. This figure actually is from about up to 2011. So I do suspect that when we get updated figures, though, it will actually become our leading gynecological cancer based on new cases per year since this data was published. Most cases occur in women between 65 and 75 years, and most, fortunately, are confined to the uterus at the time of diagnosis. And most women are postmenopausal and present with bleeding at an early stage. So this usually leads to prompt detection. And at this stage, at this early stage, the prognosis is usually very good, with a 5-year overall survival of about 80%. Unfortunately, though, we do have women who present at stage 3, about 13%. Survival decreases dramatically to about 30%, and at stage 4, about 10%. More than 90% of cases I mentioned are women over 50. However, about 4% are in women who are under 40. And this can present a diagnostic dilemma because women may present with abnormal menses, heavier periods. And in our setting where we have lots of patients with fibroids, then oftentimes things may be attributed to the fibroids. So we really need to have a low or have a high index of suspicion in women who things just don't seem right. So risk factors for endometrial cancer, obesity, high blood pressure, diabetes, so the metabolic syndrome cascade, prolonged exposure to estrogen, often related to nulliparity and infertility associated with like polycystic ovarian syndrome. Also, women on tamoxifen treatment are more than 2 times likely to develop endometrial cancer. And these are women on tamoxifen are often women who are being treated for estrogen receptor positive breast cancer. Globally, the incidence of endometrial cancer has been increasing, and have been seeing more cases here locally as well. And this is thought to be attributed, or is attributed, to the increasing incidence of obesity. Most cases are sporadic, but about 5 to 10% of cases are hereditary, usually a part of the Lynch syndrome, which increases the risk of colorectal cancer. And we may also see cases in Cowden syndrome as well. And these women with Lynch syndrome have an increased risk of colon, endometrial cancer, and even ovarian cancers as well. So there are 2 main types of endometrial cancers. Type 1 are more common, and these are the types that are usually called the endometrioid types. They tend to be more well-differentiated, more well-behaved, and present at an earlier stage with a better overall survival. The type 2s, however, comprise non-endometrioid types. They're poorly differentiated and more aggressive. And these are the ones that tend to present at a more advanced stage. And these are the serous, clear cell, undifferentiated types, carcinosarcomas, also known as the triple MTs. Unfortunately, in our setting and other countries are predominantly Black women, we actually find higher incidence of type 2 endometrial cancers. In a 10-year review I did some time ago, not yet published, we actually found that we have a 50-50 proportion of type 1s and type 2s. So we have a lot of the aggressive types here in our setting. This dualistic model classifying endometrial cancers into type 1 and type 2s does have some limitations. For example, some type 1 cancers, endometrioids, supposedly well behaved. In 25% of cases, they behave more like the aggressive type 2s and exhibit more P53 mutations, which is seen more in the serous types. So recently, they have revised or added this new classification system for endometrial cancers, which uses, and this was derived from the Cancer Genome Atlas. And they actually classify them now into Pol E ultramutated, which are the more favorable types, microsatellite unstable types, which are similar to those seen with Lynch syndrome. Copy number high, which have predominantly P53 mutations, and then the last category with no specific mutation or profile. So the standard approach for management of endometrial cancer is hysterectomy with removal of the ovaries, with or without lymph node removal as well. The ovaries, however, can be conserved in women who are 40 years and under, provided that they're appropriately screened and deemed to be low risk of coexisting ovarian cancer or pathology. Adjuvant radiotherapy and chemotherapy may be needed after surgery. And this is dependent on factors such as the histological type of cancer, if there is evidence of positive lymph nodes after surgery, if there is lymphovascular space invasion or other pathological features noted after surgery. Fertility sparing can be offered in carefully selected women. And remember, I mentioned there are about 4% of women who are under 40. And these women would be keen on being offered some type of fertility sparing options. So we should tell our women that the response rates are about 75%. Using this approach, it is not standard of care, and the recurrence rate is high, about 30 to 40%. So standard therapy is proposed, but if women will respond to this treatment, they will encourage them to get pregnant as soon as possible. If not, if pregnancy is delayed, then we continue treatment for another 6 months. Once they have achieved pregnancy, then we advise them to have a hysterectomy done. And the treatment for fertility sparing is usually hormonal, medroxyprogesterone acetate, megestrol acetate, or the levonorgestrel intrauterine device, with or without DNRH analogs. So response must be assessed for 3 to 6 months after treatment. So these are persons we have to monitor very closely. The live pool birth rate from one study was about 28%. So 28%, roughly a quarter of these women were able to achieve a pregnancy and a live birth, and it was actually increased to 39% if assisted reproductive therapy was involved. Unfortunately, pregnancy is associated with a reduced risk of recurrence. So I put this algorithm here just to highlight the women who would be considered for fertility sparing treatment. So they have to have a well-differentiated grade 1 endometrioid, so no other histological type, and has to be grade 1, involving just the endometrium. So on imaging, we're confident that it doesn't involve the muscle, just the lining. Absence of suspicious disease or any metastatic disease on imaging. No contraindication to the hormonal therapy, which will be used. And also, they should be counseled that this option is not standard of care. And the close follow-up. So they should be amenable to close follow-up as well. Now let's look at cervical cancer. So globally, this is the 4th most common after breast, colorectal, and lung. However, in developing countries like here in Jamaica, it's actually the leading gynecological cancer. So we had about 15.7 per 100,000 cases in the last review, compared to the global average now about 13.3. So just a little above the global average. Most cases globally are seen in low middle income countries. Women are younger, generally with cervical cancer, with a mean age of about 50 years. And it's strongly correlated or strongly linked to infection, persisting, transforming infections with HPV. Of all the HPV types, about 13 high-risk types or cancer-causing types exist. And of these cancer-causing types, types 16 and 18 are the most oncogenic of them all, accounting for about 71% of cases. What we should note is that most HPV infections are cleared within 2 years from the time of acquisition until clearance of infection. And only about 10% of cases become transforming infections. So it's a norm for HPV, for women to have an HPV infection. It's a norm for women to clear this HPV infection. But in 10% of cases, then they may progress. So here we see the trend in our cervical cancer incidence over the last few reviews. And we've been doing, well, it's coming down pretty nicely from 25.2 in 1993 to 97. And in the last paper, 2008 to 2011, 15.7. And as I mentioned before, endometrium was sneaking up right behind it at 14.6, 14.8. And as I said, I suspect when the final review is complete, we're going to see endometrium surpass cervix. So we're going to be dealing with first world or developed country challenges with endometrial cancer, and we still have a problem with cervical cancer. So what are the risk factors for cervical cancer? So infection with HPV, as mentioned, high-risk HPV, early age of sexual debut, multiple sexual partners or having a high-risk partner, immunosuppression, so after organ transplantation, or in women living with HIV, And in women living with HIV, they are 5 to 6 times more likely to develop cervical cancer. History of other STDs, a history of vulval or genital HPV infections, not attending for screening. This is a big one, in addition to cigarette smoking. We actually have local papers which show that high-risk HPV prevalence was not correlated in any way to other social factors such as marital status and number of partners and so on. But useful to know that these are the traditional risk factors, but at the end of the day, not screening is the biggest risk factor. Studies show that 50% of women who develop cervical cancer and another 10%, or 50% who develop cervical cancer have never had a cervical screen done or a pap smear done. And another 10% didn't do one within the last 10 years. So overall, there are 60% of women who develop cervical cancer who haven't been appropriately screened. So screening is one that we need to remember for sure. Just a bit more background on HPV. There are about 200 HPV subtypes divided into species and genre. And all the oncogenic types are found in the alpha here, alpha genre. And they're distinguished by the gene sequences of the L1 protein in the caspid. And over 200 types, over 60 types affect the anogenital mucosa. So how do we manage cervical cancer? Well, treatment exists on a spectrum, from cervical colonization to for microscopic disease, which a portion of the cervix with the transformation zone is removed, to trachelectomy, from microscopic disease again, with more concerning features such as lymphovascular invasion or larger microscopic tumors, or even macroscopic tumors, obvious tumors that are less than 2 centimeters, may be amenable to trachelectomy, where we actually just remove the cervix and surrounding tissues and upper vagina. And of course, we have to reinforce the lower part of the uterus with a circlage or stitch to ensure that this woman doesn't have issues with mid-trimestral losses or miscarriages. And of course, we have our hysterectomy. It can be simple hysterectomy with pelvic node removal or a more extensive radical hysterectomy. Adjuvant chemoradiotherapy can be given after surgery, depending on certain features at the time of surgery, whether there are lymph nodes being involved or the tumor is invading the lymphatic and vascular channels within the cervix and so on. So some women after surgery actually do need to go on and get radiotherapy. We actually try to limit treatment to either surgery or radiotherapy. So we try to carefully select patients and choose either one or the other option. However, in some cases after surgery, we do end up having to recommend adjuvant radiation. And in the very advanced cases where surgery isn't possible, then primary chemoradiotherapy, or in persons who are not fit surgical candidates, then primary chemoradiotherapy is done. So of course, the take-home message from this is it pays to pick up cervical cancer early if it is that cervical cancer develops, so we can do a simple procedure, colon biopsy, rather than having to do something more extensive like a hysterectomy. And what about pregnancy outcomes following trachelectomy? So as mentioned, it's used in 1A, 2 disease, even 1A1 disease, some cases up to 1B disease with less than 2 centimeters. In a review looking at about 300 pregnancies, 300 women who got pregnant after trachelectomy, 10% of them actually had a mid-trimester loss, second trimester loss, but over 70%, 72% went on to deliver at term. And it can be done vaginally or abdominally. And abdominal trachelectomy has the advantages of allowing us to do bigger size tumors rather than being limited to about 2 centimeters with the vaginal. So radiation with or without chemotherapy is usually used, as mentioned, in advanced disease, and it's not without complications. Vaginal stenosis, so shortening and narrowing of the vagina, fibrosis, pain with intercourse, and compared to surgery alone, primary or adjuvant radiotherapy has been associated with greater sexual dysfunction and vaginal complications. The combination of surgery and radiation, which I mentioned, does happen at times, results in increased vaginal shortening and also increased sexual dysfunction, in addition to premature ovarian failure and the bowel and bladder dysfunction, which can occur. And unfortunately, most of the patients we see with cervical cancer present late and are not candidates for surgery and have to be referred for radiotherapy. In terms of surgical effects, in managing cervical cancer, these include orgasmic problems, vaginal shortening, pain during intercourse, lymphedema because of extensive removal of lymph nodes, genital numbness, and overall sexual dissatisfaction. Compared to radical hysterectomy, the regular radical hysterectomy, nerve-sparing radical hysterectomy is an approach that can reduce some of these bowel and bladder dysfunction and also some of the overall sexual dysfunction complications. And trachelectomy, which was mentioned as a fertility-sparing option, isn't without its complications as well. In a small study, patients who underwent this procedure actually had some worsening of arousal, lubrication, orgasm, and also pain. Fortunately, most of these symptoms improved by 6 months. Now, finally, let's take a look at ovarian cancer. So malignant tumors of the ovaries occur at all ages with variation in histological type by age. So for example, in women under 20 years, we tend to see mostly germ cell tumors in this age group. Borderline tumors tend to occur between the 30s and the 40s, and are invasive epithelial cancers usually after age 50. The lifetime risk of developing ovarian cancer is about 1 in 70. And ovarian cancers account for about a quarter of all our gynecologic cancers, but yet they account for about 50% of deaths from gynecological cancers. So they tend to be the most aggressive of all the gynae cancers. So ovarian cancers are a very interesting and heterogeneous group of conditions. So for example, using this diagram here to demonstrate the different types, we can see the surface epithelium here, and this is where most cancers develop. Most of these are epithelial ovarian cancer, 90%. And of this group, the serous types predominate, high-grade serous. There is a low-grade serous, which is a different entity which has a different, develops from a different pathway from the high-grade serous. What's interesting about this high-grade serous, even though it's a primary ovarian cancer, it actually starts or is thought to arise from the fallopian tube, from what we call stick lesions. So serous tubal intraepithelial carcinoma. So lesions in the tube, which actually give rise to fallopian tube and ovarian cancers. Mucinous tumors, most of these are associated with gastrointestinal tumors. Right, so whenever we suspect or diagnose a mucinous ovarian tumor, we need to rule out gastrointestinal. So we need to have our upper and lower GI endoscopy done. At the time of surgery, we need to closely examine or even remove the appendix as well. The endometrioid and clear cell cancers actually arise from deposits of endometriosis in the ovary. So even though these are all primary ovarian, they do have their origins in other organs, which is very interesting. Moving along to the sex scarred stromal cell tumors. Of these, this is where the hormones are produced in the ovary. So many of these are hormone producing. The most common is a granulosa cell tumor, and this actually results in increased estrogen production and all the side effects or effects of that. So for example, in a patient who is prepubertal, then she may present with precocious puberty. Somebody during the reproductive years may present with heavy menstrual bleeding, abnormal uterine bleeding, and a postmenopausal woman may present with postmenopausal bleeding. Interestingly enough, because of the excess estrogen production from these tumors, actually a quarter of these patients actually have coexisting endometrial cancer or hyperplasia. So we should always rule those out when we're managing or suspect a granulosa cell tumor. And the germ cell tumors are developed from the germ cells. Most common is a dysgerminoma, which is the one with the best outcome, I would say, versus the yolk sac and teratoma, which are seen in about 20% of cases, and which are more aggressive, especially the yolk sac tumors are more aggressive. So some ovarian cancers are hereditary, about 20% of cases. Most of them are associated with BRCA1 or 2, and there are other genes as well, which give rise or increase the risk of hereditary ovarian cancer syndromes. And because of the strong link with breast cancer, about 80% for BRCA1 and 2, and 40% risk, 40 to 60% chance of ovarian cancer with BRCA1 and about 25% chance of BRCA2, we strongly advise that women have risk reduction surgery. So for example, for bilateral salpingo oophorectomy, they should have this done by age 40 for BRCA1 patients and 45 for BRCA2 patients. Of course, after appropriate counseling and so on. And additionally, there are no effective or documented screening strategies for ovarian cancer. And most patients present late, at least stage 3. So we really need to counsel our patients who are at increased risk of ovarian cancer. So as mentioned, most patients present with advanced stage disease. Here I have a picture showing a laparotomy, some omental caking seen here, tumor around the bowel. However, what we have found though is that even though most patients present late, it's said to be a silent disease. We have found that there are patients who actually have some bowel symptoms in the early stages. So they're non-specific, and oftentimes they get misdiagnosed as having GI pathology, and it turned out to be ovarian cancer. I'm actually remembering one such patient, very much like this. She did endoscopies and was seeing a gastroenterologist, and later on turned out to have ovarian cancer. So the aim of treatment for ovarian cancer, or the best approach to improve overall survival and reduce recurrence, is actually upfront debulking surgery. So what this means is when we go in for surgery, we try to remove all obvious disease. So in anywhere there is tumor, so if we do a hysterectomy, take out the ovary, tubes, uterus, cervix, all obvious disease that's seen anywhere else. Right? If it is that we don't think we are able to achieve this at the time of surgery, then we get a biopsy to confirm the histology, give chemotherapy, platinum-based chemotherapy for about 3 cycles, reassess, then go in to do surgery if possible, and then give chemotherapy for 3 more cycles. So that's neoadjuvant chemotherapy. Because in leaving back residual tumor, then we increase or reduce the overall survival of these patients. But what is found, if we look at this chart here, is that overall survival is best with upfront debulking surgery, then chemotherapy. So there's primary debulking with no residual tumor seen. But it's also good if we give neoadjuvant chemotherapy and then we go in and have no residual tumor left as well. So that approach is very good. It prevents us having to go in, leave back tumor, and that doesn't help the patient in any way, right? So neoadjuvant chemotherapy is utilized a lot, especially in our setting. If patients aren't fit for extensive debulking surgery, we have to think about blood availability, intensive care space, and so on. So it's an approach that's utilized quite a bit. Additionally, most patients with ovarian cancer are going to recur. So usually they respond well to platinum-based therapy most times, but oftentimes within 2 to 3 years, 70% will recur. And when they recur, the outcome or success of future treatments, whether it's secondary chemotherapy or repeat surgery, secondary cytoreductive surgery, hinges on how well they're managed in the first place. So if they're managed upfront with surgery with no residual disease, whether it's after neoadjuvant chemotherapy or primary surgery, upfront surgery, then they tend to do better with subsequent recurrences. With ovarian cancer patients, of course, the main concern after this is the resultant menopause, which can be abrupt and intense if not managed appropriately, because they go through surgical menopause, ovaries are out, and this can have impacts in all areas of the life, especially as it relates to sexual dysfunction, they have vaginal dryness, dyspareunia, decreased libido, and so on. And then we mentioned that chemotherapy and radiotherapy plays a key role in managing, in addition to surgery, are utilized heavily in managing our patients, especially late-stage patients. And these also aren't without their side effects. So with chemotherapy, commonly we have nausea, vomiting, the bone marrow suppression, which can cause anemia, low platelet counts, low white blood cell count, or everything can be low, the pancytopenia. Right, nephrotoxicity, neuropathies, we tend to see quite a bit of neuropathies as well. And we can't forget alopecia. So this is the one thing that I think most women fear when they hear the word cancer, when they hear chemotherapy. It's actually the hair loss. Radiation has its effects as well. We mentioned the vaginal changes, the bowel bladder dysfunction, ovarian failure, bone marrow toxicity, and so on. I actually found this, saw this picture of this patient here who was on the MD Anderson website, and she actually developed permanent alopecia. So most times we can reassure the patient that the hair will grow back, but in some cases it may not. And for her, that was the case. But she's embracing this new look. She said, no wigs for me. She rocks it bald. And they're going through, you know, different ways that we can try to reduce or manage the alopecia. Scalp cooling, scalp compression, or scalp cooling and compression, minoxidil, and so on. So, you know, several options can be used to help to reduce this. For the neuropathy, there's acupuncture, which she stated works quite well for her, and vitamin B, which is what we tend to prescribe for a lot of our patients. And then in addition to traditional chemotherapy, we actually have targeted therapies, which aim to reduce the side effects from traditional chemotherapy, because they're supposed to be more targeted in their approach to damage induced cancer cells. We utilize these agents a lot with our metastatic disease, high-risk disease, recurrent disease. So what we have available to us now in gynecological cancers is anti-androgenic agents like bevacizumab or PARP inhibitors for persons who are BRCA or BRCA positive with ovarian cancer to reduce the recurrence risk, estrogen receptor downregulators, and we have our checkpoint inhibitors as well. So here again, we have some of these agents, Bev, being used for ovarian cancer, cervical cancer, the PARP inhibitors, again, for ovarian. The pembrolizumab can be used alone for endometrial cancer and cervix, and also combined with an anti-VEGF agent, lenvatinib, for endometrial cancer. And of course, these are for advanced recurrent disease, because, for example, endometrial cancer generally presents early, good overall survival, but when you have a recurrent endometrial cancer, it can be quite challenging to manage. And this picture here just highlights how our immune checkpoint inhibitors work. So when we have our dendritic cells presenting antigens, whether it's bacteria or cancer cells, to our T cells for our immune system to then destroy these cells, we have these things called checkpoints in our bodies. But the checkpoints override the ability of the T cell to destroy the pathogen. So we have inhibitors of these checkpoints, which then allow our immune system to destroy these pathogens or cancer cells in this case. So these checkpoint inhibitors can act at a priming phase, which is where the dendritic cell speaks to the T cell, or they can act at the effector phase, which is where the T cell then destroys the cancer cell or the pathogen. So at the priming phase, we have the CTLA-4 inhibitors, and at the effector phase is where you have the PD-1, PD-L1 inhibitors. So that's really the premise on which these immune checkpoint inhibitors work. And of course, they too aren't without their side effects. So there, the side effects are called immune-related adverse effects, and they result in inflammation throughout the body. So you can have colitis, neurotoxicity, can have skin conditions, pneumonitis, hypophysitis, thyroiditis, myocarditis. So you can see the list is quite extensive here. So in managing these, the treatment can be held depending on if it's a grade 1 or 2. In some cases, steroids can be used, either oral steroids, topical steroids. In some cases, the treatment may even need to be stopped. So in mentioning all of these treatments, surgery, chemotherapy, targeted therapy, we have seen how these can affect quality of life. And because of this, we have several quality of life tools that are recommended. So in looking at new treatment strategy in managing a cancer patient, we're not just focusing on oncologic outcomes. So we're not only interested in progression-free survival, overall survival, but we're also concerned about toxicity as well as efficacy of these treatments. And there are several tools which can be used. There's the European Organization for Research and Treatment of Cancer, and there's also the FACT tool, which is a lot simpler to utilize. But most studies now are, in addition to stating oncological outcomes, are also giving us information on quality of life impact with these treatments, which is very good. I actually presented a poster and have this abstract in the International Journal of Gynecological Cancer some years ago, where I did a small study looking at quality of life of different treatment approaches in our patients in gynecological cancers. What about 120 women? And we looked at 4 domains using the FACT-G tool. We looked at their physical, social, functional, and emotional status. And we're happy to see that our patients actually had scored pretty well in all domains. And we didn't find much difference at baseline, which is when they're just presenting to us. 6 weeks post-treatment, and even up to 6 months post-treatment. So we're finding that our patients actually had good quality of life scores in that study. So after treatment, then we embark on surveillance. So we see patients at regular intervals following treatment, initially for every 3 to 6 months, for up to 2 years, then every 6 to 12 months, for up to 3 to 5 years, and then annually dependent on the risk of recurrence. We do a detailed history and examination. We may have to do laboratory testing, for example, CA125 in our ovarian cancer patients, wall smears in cervical cancer patients, but we need to be mindful of those having done radiation therapy where the smears may not be very useful initially. Baseline imaging is usually done 3 months after treatment and then repeated dependent on clinical findings. For some tumors, for example, ovarian germ cell tumors, which replicate very fast, they actually require closer follow-up. So initially every month, they may need to be seen for the first year. And we may need to do extensive surveillance for some tumors like our granulosa cell tumors, which are very slow growing and indolent and may recur even up to 40 years later. So surveillance falls under a bigger umbrella of what we call survivorship. So survivorship care of cancer patients is from the time of diagnosis through to the rest of our life. So we actually have survivors who are those living with cancer and those who are free from cancer. So survivorship care encompasses improvement of health, wellness, and quality of life. And it also includes our family members, friends, and caregivers of these patients. So it entails prevention and surveillance, which was mentioned, looking for any recurrent cancers or new cancers. During this phase, we encourage women to have mammographies done, ensure that they do their colonoscopies and so on. Assessment of late psychological and physical effects of cancer as well, and treatments. Control of medical comorbidities, and strong partnerships and referrals are formed between us, patients, and their primary care specialists as well. So there are several domains to survivorship: physical. We discuss pain management, which we could talk about for a whole day. Shortness of breath, anorexia, fatigue, lymphedema, any underlying medical condition. Mental health, very important, which we'll be talking about later on. And which encompasses depression, anxiety, post-traumatic stress, the sexual health, spiritual health, even social habits. So we encourage them to not drink, stop smoking. We talk about sleep, nutrition, exercise, vaccination. So it's quite extensive. As it relates to physical activity, this guideline is from the NCCN, recommending different levels of activity for patients who are patients living with cancer or have recently been treated for and recovered from cancer. So we have light activity, which includes childcare, light household work up to moderate, which can be general gardening, exercise such as yoga or Pilates and so on, brisk walking up to high intensity, so heavy gardening and high intensity walk, yoga, uphill walking, jogging, running. So they recommend about 150 minutes of moderate intensity exercise recommended, with an ultimate goal of about 300 minutes. So they should aim for about 2.5 to 5 hours per week. For vigorous, then about 75 minutes per week, and so on. And you can have a mixture of moderate to vigorous activity as well. But of course, they should all start with light intensity, aerobic warm-ups and stretching. So this guidance here is from the NCCN. There are physical challenges, though, that can make activity difficult for cancer patients. For example, lymphedema, I would recommend physiotherapists, and there are some who are specialized in managing this condition. There are pumps that can be used, compression devices, and so on. For persons with a stoma, we recommend exercises which do not increase intra-abdominal pressure, and also use of stoma protectors as well. Many patients suffer from peripheral neuropathy. They're encouraged to ensure that they check their gait and stability before embarking on exercise. They should do balance training, ideally with a partner or coach first. As it relates to weights, they should use weights with soft coverings or padded gloves, or just use resistant bands instead of weights for safety. For those with bone loss, we encourage weight-bearing exercises with a trainer and also their vitamin D supplements. As it relates to nutrition, there's a lot that can be said on nutrition. Some are a bit controversial, but there are several things out there about nutrition and cancer and what can cure cancer and what will encourage cancer growth and so on. So you have the macrobiotic and ketogenic and intermittent fasting. And these are some of the books I've read. A very interesting book, Fat for Fuel, is about ketogenic diet. I used to have cancer, is about this gentleman who used the macrobiotic diet. So there's a lot of information out there. But we do have some guidance from the NCCN again. And they state, of course, eat real food, plant-based food, fruits and vegetables, healthy fats, legumes. We should limit the red meat consumption to about 1 pound per week. Limit refined sugars to about 6 teaspoons per day. Avoid or limit alcohol and smoking. Get good sleep, 7 to 9 hours. Avoid processed meats, which are strongly linked to cancer. And avoid processed foods as well. So that's a useful guide. As it relates to supplements, again, controversial. There are some papers, especially one recently, saying that some vitamins may increase the spread of cancer. Some may interact with cancer treatment in persons who are still undergoing treatment. There are persons who swear by vitamin C therapy for in managing cancer. So there's a lot out there as it relates to the supplements. For the immune system, though, cancer survivors may be at risk of infections for several reasons. So the spleen might have been removed, for example, in ovarian cancer debulking, radiotherapy, they may have bone marrow suppression, and several reasons. So we encourage or talk to them about good hygiene, hand hygiene practices, wearing masks when traveling, wearing gloves when gardening or dealing with animals, take appropriate antimicrobial prophylaxis, for example, on the vaccinations. And here we have just a regime or some guidance on vaccinations in patients with cancer. So for non-live vaccines, they should be given at least 2 weeks before cancer treatment or 3 months after chemo or radiotherapy, and at least 6 months after bone marrow transplant. For live vaccines should be given 4 weeks before treatment or 3 months after chemotherapy. I have examples here of our live and non-live vaccines. And we have been talking a bit about this as well, about sexual health. And we spoke about the different ways in which the diagnosis and treatment of these gynecological cancers can impact sexual health. And of course, because of the anatomic location of these cancers, these patients are among the most severely affected by sexual dysfunction. It has been reported to be as high as 90% in these patients, and it's multifactorial. So it can affect patients in any phase of the sexual response cycle, from desire, excitement, plateau, to orgasmic dysfunctions, and so on. But unfortunately, it's found that sexual health isn't discussed often enough with our patients. So despite the high prevalence of sexual dysfunction, attention is rarely paid to this issue. What are the reasons for this? It could be a lack of training and skill to deal with the concerns on the part of the physician, embarrassment when talking about sex, concerns about offending the patient, or we may underestimate the prevalence of sexual dysfunction, or we may underestimate the impact that the sexual complaints may have on the patient's health and well-being. Studies show that most patients actually would like to be more informed and would want to discuss these issues with their team. In a study of gynecological cancer survivors, they found that 74% of survivors believe that the physicians should discuss sex, and 62% reported never discussing the effect of having this discussion. So it's essential for the care of our gynecologic cancer patients that sexual health issues are discussed, evaluated, and treated. And of course, the management is multidisciplinary, but it begins with talking to the patient and being honest with them from even before treatment, and it's found that this improves post-treatment adjustment. The brief sexual symptom checklist is a useful screening tool that can be used, and we can try initially preventative approaches, so nerve-sparing techniques, as mentioned before, for hysterectomy, ovarian transposition. So we try to move the ovaries out of the radiation field if possible, and also conserve the ovaries if necessary. So I mentioned in women with cervical cancer, premenopausal, we don't need to take the ovaries out. Women with endometrial cancer under 40, some guidelines 45, we can talk to them about leaving the ovaries in as well. Hormonal therapy can be used, so hormone replacement therapy. We have challenges here locally with hormone replacement therapy for several reasons, but this can be used in select cancer patients. So women who have hormone-sensitive cancers, of course, we would not want to use them, but generally for cervical cancer, hormone replacement therapies can be used. Vaginal estrogen cream can be used across the board. Lubrication, vaginal dilation is enforced and encouraged for all patients undergoing radiotherapy. pelvic floor physiotherapy. There are several papers showing that this is beneficial. Vaginal laser therapy as well, using the CO2 laser. I recently engaged a colleague who does vaginal or what's it there now? A reconstructive gynecology and our cosmetic gynecology, I should state, about seeing if we can get some of our patients to benefit from some of these vaginal laser treatments, because there are some papers which show some promising results in women who have stenosis and atrophy secondary to radiation therapy, psychotherapy, and of course couple rehabilitation. So we get the partners involved. And reproductive options, we mentioned fertility sparing treatments. These should be, encouraged. Our young women should have these discussions. They have cancer, yes, but is there something that can be done to give her a chance for future fertility? And we went through some of these. Referral to fertility specialists, egg donation can be discussed, adoption, surrogacy, and uterine transplant actually has been showing some promise. There have been patients who have actually conceived from uterine transplantation. Spirituality is something else that can be discussed. A broader concept than just religion, and it's actually been shown to reduce depression and morbidity generally. Right, in a study in non-cancer patients, they found that 77% of patients actually want their physicians to address their spiritual needs. 1/3 wanted to be asked about religious beliefs at office visits. 2/3 thought that their physician should be aware of their religious beliefs. And the patient's desire for engagement in this actually increased with the severity of the illness, as we can imagine. And interestingly, it stated that African Americans were more willing to spend a portion of their office visit discussing spiritual concerns over the medical concerns. But how should we approach this, or how can we approach this in our patients? And what should we do with the information that we get from this? Many physicians may feel unprepared to have these discussions, but an option is to engage the services of a chaplain. So I actually have the chaplain on speed dial at the university on my phone. All right, so psychological health, I won't get into this because this will be discussed, but just to know that depression in cancer patients is very high, and it increases the mortality rate as well by up to 30%. So we have found that chronic stress via the HBO, hypothalamic pituitary adrenal axis, and activation of the sympathetic nervous system releases stress hormones, right? And the chronic stress and these stress hormones promote cancer development and progression through DNA damage and decrease p53, which is our tumor suppressor gene, and other related pathways. So stress is associated with poor oncological outcomes for many types of cancers, including breast and ovarian. And they have found increased glucocorticoid levels accelerate metastasis of breast cancer and causes a lower survival. And finally, just to touch on financial toxicity from cancer treatments. The cancer treatments options have increased dramatically. I mentioned some of the new targeted therapies, the bevacizumab and the pembrolizumab and so on. They do come at a cost. And several cancer survivors actually experience financial adverse effects from these treatments, and are twice likely to file for bankruptcy. And the financial toxicity is inversely related to quality of life. So patients may actually skip appointments. They may reduce the medications or not take the medications at all. So as healthcare providers, we should acknowledge the financial burden when discussing treatment options to ensure compliance as well, if that's at least one thing that we can assist with, to ensure that they'll be compliant. Why are they not taking the medications, coming to visits? We may not be aware of actual cost, but recognizing that there's some financial challenge may empower patients to discuss what they're experiencing and help us to help them. All right, so we can look at regimes that may be cheaper if they have similar efficacy, or even explore non-governmental organizations. So we've written to Chase Fund a few times, or we can try to enroll our patients in clinical trials as well. The caregivers should not be left out because there are also high levels of anxiety and depression among caregivers of cancer patients, especially the spouses. In this study, only by GOTSI 2014, they found that only 4% of family caregivers and none of the bereaved family members receive psychological support. So psychological interventions can reduce psychological distress, it can reduce depression, anxiety, and also improve the health status, because sometimes these caregivers also are battling with other health-related conditions as well. And divorce in cancer patients is real. And this study looking at 263,000 cancer patients, they found that cancer was associated with a slightly decreased divorce rate, except for cervical cancer, which was associated with an increased rate of divorce. Not sure why that is, but from that systematic review, the two studies identified this. One, it was a 1.36 times odds ratio, while another one was actually a risk ratio of 2. And lastly, support groups can encourage our patients to seek out support groups as well. It helps them to build bonds, express their emotions, help them to cope better generally overall. I do find though that some patients actually experience more anxiety from support groups. One patient told me that when things are going okay, it's helpful, but sometimes a patient might come in and say they have a recurrence, and it brings them down a road of anxiety again, and they start to relive, bad experiences. So it's not for everyone, but this is something we can inform our patients about. So in summary, quality of life issues are of special concern to women with gynecologic cancers. Care for these women includes attention to their physical, emotional, spiritual, and mental health, not only oncologic outcomes. Fertility-sparing approaches to treatment should be discussed where necessary, and quality of life checklists should be incorporated into our patient care before, during, and after treatment. And also, our family members and caregivers should be included and supported in this journey. Thank you for your attention.
Dr. Medley, thank you so very much. Wow, that was a very comprehensive yet very well focused on key issues in gynecologic cancers. And can I tell you, I enjoyed the whole presentation, but especially the last 10 to 15 slides were really excellent. So, doctors always know how to treat, issues, or most times, what kind of medication, what kind of treatment strategies to use. But sometimes the most important thing is navigating life around your diagnosis and post-diagnosis and during cancer remission, etc. And trying to achieve back or attain wellness, so you really, really focused on that, Dr. Medley. It was an amazing presentation. Thank you so very much. I know you have a lot of questions or comments based on that. I see a lot of claps and wonderful presentations coming your way. Thank you so much. You obviously are very passionate about your area of work, and though I a lot of experience and expertise. Thank you so much for taking the time this evening. And of course, you're going to stay back with us for the Q&A and discussions. Thank you so much, Dr. Medley. I think we're gonna, Sam, are we going to do a sponsor presentation, a short break? We have
That's
to
correct.
acknowledge our sponsors, without whom like this become very difficult. So over to you, Sam.
Good evening, ladies and gentlemen. This is Lisa Hubbard, medical representative from Medipex Jamaica Limited, where we provide first-class products for healthy living. I'm going to present two products from our portfolio today. The first one is Stimulotan, and it's our sertraline 50 milligrams, and it's a selective serotonin reuptake inhibitor, better known as a SSRI. So, mechanism of action. They act within the brain to increase the amount of the neurotransmitter serotonin in the synaptic gap by inhibiting its reuptake. This helps to ease the symptoms of mood disorders such as depression and anxiety. Indications are depression, panic attacks, and obsessive compulsive disorders. SSRIs have become the first choice treatment for depression owing to their excellent efficacy, safety profile, side effect profile, and onset of action. So the dosage. Depression and OCD, it's 50 milligrams once daily with food, complete therapeutic effect after 2 to 4 weeks. For panic disorder, the first week, it's 25 milligrams once daily with food, and from week 2, 50 milligrams once daily with food. Expect complete therapeutic effect after 8 to 12 weeks. and your maximum daily dose is 200 milligrams per day. Stimulating can also be used for premature ejaculation, which is an off-label indication. And for this, it's 50 milligrams OD for 6 weeks, then when needed thereafter, or prophylaxis, 50 milligrams PRN 2 hours prior to sexual intercourse. And this is your dose adjustment required for special populations. So the benefits. Sertraline is among the most potent SSRIs. Age has no influence on sertraline clearance. Plasma levels and clearance can be quickly and effectively controlled, and it has a small effect on the CYP enzymes, thus reducing drug interactions. So Stimulotan, offering choice to your patients. It retails at approximately $140 per tab. NHF subsidy for this drug is $45 per tab, so the patient will pay approximately $95 per tab after NHF coverage. So Stimulotan lifts you out of depression. The second product I'm doing is Polixid, which is our donepezil hydrochloride, and it comes in 5 and 10 milligrams. We can't speak about Polixid without talking a little bit about dementia, and there are several types: Alzheimer's, vascular dementia, Lewy body dementia, frontotemporal dementia, Parkinson's disease dementia are just some of the common types. So Alzheimer's disease is the most common cause of dementia. The term dementia describes a set of symptoms which can include loss of memory, mood changes, and problems with communication and reasoning. These symptoms occur when the brain is damaged by certain diseases and conditions, including Alzheimer's disease. Alzheimer's is a progressive disease, which means that gradually over time, more parts of the brain are damaged, and as this happens, the symptoms become more severe. People with Alzheimer's also have a shortage of some important chemicals in the brain. These chemicals are involved with the transmission of messages within the brain, and one of such chemicals is acetylcholine, which is where our Polixid acts. So Alzheimer's disease is characterized by 2 abnormalities in the brain: the formation of amyloid plaques between the nerve cells and neurofibrillary tangles called tau within the neurons. This is a schematic of a normal brain versus Alzheimer's brain. So indications for Polixid. It's for the treatment of mild to moderately severe Alzheimer's disease. Mechanism of action. Donepezil is a cholinesterase inhibitor. It's a specific and reversible inhibitor of acetylcholinesterase, which is the predominant cholinesterase in the brain. Donepezil hydrochloride is postulated to exert its therapeutic effect by enhancing cholinergic function through increased concentrations of acetylcholine. There is no evidence that donepezil alters the course of the underlying dementing process. It just slows down the progression of the disease. So the dosage, initially it's 5 milligrams once per day in the evening before retiring for at least a month. After 1 month assessment, the dose may be increased to 10 milligrams. Your maximum daily dose is 10 milligrams. And for renal and hepatic impairment, same dosing as clearance of the drug is not affected, and it's not recommended in children. So the presentations are a round white biconvex film coated tablet. The 5 milligram retails for $10,136, and the 10 milligram retails for $11,466. So why Polixid? It's well tolerated. It improves cognition and functioning. There's a 38% reduction in functional decline, improves behavioral symptoms, and yes, there can be some adverse side effects, and they include bradycardia, GI, muscle cramps, and fatigue. And that's it. Thank you very much for your attention, and do have a wonderful evening. Bye.
Thank you so much, Lisa. Very nice presentation on 2 important drugs. Thank you so much for your presentation, as well as for your support of the CCFP all the time. All right, let's move on to our second presentation. I'm very pleased to welcome Mrs. Georgia Rose. I have not met Mrs. Rose before, but having read her CV, I'm very much looking forward to your presentation today, Mrs. Rose. She's actively involved in mental health education and early childhood development. She holds a MSc degree in clinical psychology, a Master of Arts in infant and early childhood development, and is currently pursuing a Doctor of Philosophy in infant and early childhood development. She has been providing service in child and adolescent mental health for over 19 years in the Western region, and in 2015 was recognized by the Special Education Unit of the Ministry of Education for unrelenting and untiring service to special education. She's actively engaged in community service in Western Jamaica as a consultant on the Ethics Review Board for Kidney Transplants in Western Jamaica, past chairperson for the St. James Red Cross, and past board member of the Peace Management Initiative of St. James. She has conducted numerous psychosocial support trainings across the Caribbean on behalf of the International Federation of the Red Cross. She lectures psychology at the undergraduate level at the University of the West Indies, Western Jamaica campus, and has presented on numerous topics related to child and adolescent mental health. She's delivered hundreds of lectures on mental health and wellness, and is currently compiling a book on strategies for positive parenting. She's passionate about mental health and wellness, and while she supports all clients, she enjoys working with children and women the most. So she's so well placed to speak to us at today's webinar on mental health and wellness. Welcome, Mrs. Rose, over to you.
Thank you so much, Professor. As Nani, yes. Good evening, everyone. Thank you so very much for having me. I have what I think is the easiest job of everyone that's here. You know, I'm going to be talking about something that's quite passionate for me, and that is mental health and wellness. I noticed that our previous presenter hinted at it and shared some gems and tidbits with you. So I hope I will solidify that a little bit more and you'll walk away. Yes, hold on. You walk away with a greater appreciation of the value of mental health and wellness in care. So we want to help our clients safeguard their mental health and wellness. And I want to spend a few minutes speaking to you about the benefits of promoting and advocating for mental health and wellness in your total treatment of your clients that might present with cancer. So when we think about mental health, we want you to have an understanding that it encompasses many domains. So mental health involves the psychological, the emotional, and the social well-being of an individual. I think as a people, largely globally worldwide, and even more in the Caribbean, we have come to an appreciation that mental health and wellness is so much more than just an illness. It is not something fancy. It is not rooted in spiritism. It is not make-believe. It is not something that is very discerning. It affects all of us. And the more aware and willing we are to incorporate mental health in our daily conversations and our treatment of our patients and our clients, we might be very pleased to see how much more effective our interventions are. Mental health and wellness influences how we view life, how we process information, how we feel about ourselves and others, and how we respond to our environment. It really speaks to our experience of life on a daily basis, you know, and because we have that appreciation, we can argue very strongly that it is integral to total wellness. You know, health is more than the absence of an illness. Healthcare is more than chemical formulations that are constructed in a laboratory and dispensed to patients. We come into an appreciation that how we think, how we view life, how we experience life is just as potent and powerful and meaningful in our total journey of health, of wellness. And for those of us that have the privilege of sitting with our clients, sitting with our patients and giving support and treatment and advice, you know, diagnosis and management, we do have the responsibility to help our clients understand that their wealth in terms of their health is more than the prescription paper that we often dispense. No, it is a given that when faced with major shifts in life, mental health and wellness might be compromised. That's one of the first things. Additionally, when the goal is often the preservation of physical life, the other domains of life might be disregarded. And I like to use COVID and our experience of COVID as a prime example. I can't speak for other Caribbean territories, but I can share that when COVID landed on the shores of Jamaica in March 2020, the primary impetus of our or Ministry of Health was to preserve and safeguard life, and rightly so. And a lot of interventions and resources went into preserving physical life. But what soon became very apparent was that there was so much more to living than just maintaining the air that comes in and out of our clients' lungs. The industry, the specialization came to appreciate, that having the patients physically well was not enough. They also needed to be mentally turgid, and they had no choice but to incorporate and turn to the mental health services. And I think that experience can be transcended to other specializations and subspecializations in health and the rest of life, where we come into an appreciation that care for the patient that does not incorporate their psychological and emotional well-being falls short. And therefore, we might be doing the patient and their loved ones a serious disservice because we truly have not offered them an opportunity for complete and wholesome wellness. The absence of a mental illness is not an indicator of mental health. So many people believe that if you do not have a diagnosable mental illness, such as depression or schizophrenia or generalized anxiety disorder, you're mentally well. Unfortunately, that's not true. Mental health is more than that. Many persons do not have a diagnosable mental illness, but they still experience impaired mental health. And even those of us that see ourselves in very solid places and come to appreciate ourselves in very solid ways, if we're very authentic and honest, we can confess to ourselves, that mental health is a journey. It's not a very simple thing. It's like a roller coaster ride. Some days we're up and some days we might be quite low. It is more than mental illness. It is health. And we really want to push mental health at the forefront of more things. We want to have that appreciation. This amazing study that was done by Kirby and others, conducted in January 2020, so right before COVID really made its mark on us, looked at the responses that patients experience when presented with the diagnosis of cancer. And a typology of responses was derived from the analysis. And what they shared, the four main themes that presented themselves in the client's or the patient's responses was: one, it was incongruent. It did not fit in with the patient's healthy identity. I can't get cancer. I exercise, I eat well, I don't ingest toxins, I go to sleep, I have this very balanced, positive life. Your diagnosis is wrong. Cancer does not visit someone like me. So that incongruence, it's so difficult to understand and comprehend and accept because that's for the people who smoke. That's for the people who drink. It doesn't happen to the healthy people. So that was one of the themes that came up in Kirby's study. Two, the incidental diagnosis. It came from, other investigations that were being conducted. So this is not what we came to collect. I was looking at other things, and now you're trying to tell me that I have cancer. Three, the validating diagnosis. This makes sense. I haven't been feeling well for a very long time. My feelings, my symptoms have been dismissed, or they have been assigned to other things that did not seem to fully add up. This makes sense for me. And finally, the life context diagnosis. And this is when the diagnosis came relative to other things that were taking place within the individual's life, such as, the dissolution of a relationship, a marriage, death of a loved one, going through personally, adverse situations. And this is just one more thing that's adding to that extreme period in life. No, it is a given, and we do appreciate that there are many other responses that patients and clients can have to this diagnosis. But what we found was these were some of the more prevalent and common ones. No, these findings by Kirby are quite important and very significant because what they demonstrate to us is that each client has an individual experience of cancer, and therefore a greatest source of support is to look at our clients and respond to our clients as an individual. And I talk a little bit more about this as I go on, because I think that this is one of the biggest things. I work in a type A hospital facility across the western region of the island. And one of the things that clients who are dealing with cancer often share with us whenever they come into our mental health services is how often they don't feel heard and they don't feel understood as an individual. They often feel like, it's just another patient, going through the motions. And that has its own unique impact. We cannot ignore the family. And my previous presenter spoke to that, because the family is a part of the unit that goes through this journey of cancer. So the diagnosis impacts and affects not only the client or patient, but it also impacts and affects the family members and the caregivers. We think about the children, and the effect is far-reaching depending on the age and stage of development of the child and the nature of the relationship. And it's quite critical that we understand that the diagnosis has so many different meanings for different individuals, because if you are a mother, the fear becomes, will I leave my children behind? If you are the primary caregiver, then the fear becomes, how will my family survive without me? So we completely appreciate that, the impact is long lasting. Incorporation of mental health support in treatment increases positive responses and supports adherence and compliance. I want to strongly encourage that we do not hesitate to recommend mental health referrals for patients. And the way we make the recommendation is just as important as the recommendation. So, I often remind clients that you come to see us not because you have a mental illness, but you also come to see us because we don't want you to develop a mental illness. We want to safeguard your total health and well-being. So it's good to come to see us and sit and have a talk about how you're managing, how you're journeying through this part of your life. Bearing in mind that for each of our clients, this experience varies. Some of our clients might be doing very well. They've got great support. They've got that character that allows them to face adversity, in a very bold way, for want of a better term. Some of our clients might be thriving, but some of our clients might be barely surviving. Some might be struggling, and some might be in crisis. And an appreciation that wherever our client falls along this pendulum makes a difference in how well they respond to treatment and receive the intervention of treatment is quite powerful. So often as clinicians, we become immune to the illness. I know, for all of us that work in health and work with patients, it is important that we're able to separate our emotions from the care, because we need to be present for our patients in a very solid way. But we run the risk of becoming, a little cold and so detached that we lose our humanity and we are very clinical. Are you sleeping? Are you eating? Any pains, any aches? Okay, here's a prescription. Come back. We'll see you in a month, 2 months, 6 months, a year. And the humanity is removed. We want to always be reminded that as the doctors, you serve such a vital role in your patient's recovery. Your presence, your words, your support, makes a meaningful difference. The bedside manners is just as important as anything else. The art of the service is critical to how well the patient does. So I don't want you to be crying at the patient's bedside, but I do want us to have compassion and to recognize that as much as this might have been your 1,000th cancer client, this might be the first time for this patient, and it might mean so many other things. We want to remind our patients, how do we support them? And I often remind our clinicians that we're not asking you to take on the role of the psychologist or the psychiatrist. We each must be respectful of each other's specialization and each other's skill set. But there are little basic things that you can do before the clients get to us. And in the event that the clients never get to us, help the clients understand that their journey is their own. They may know 100 persons who have journeyed with cancer, but their journey is such a private and individual journey. It's great to share and get that community support. That makes a big difference in your healing, but it's critical that you understand that your experience is valuable. You know, encourage clients to be honest about how they're doing, so to take ownership of their journey with cancer and to be willing to evaluate how well or not well they are doing. Remind them to invest in good relationships, supportive relationships. And this is where the true caregivers come in. You know, those people who help them to stand in this difficult space and move through it as best as they can. To identify strategies that work for them, this is critical. And this is also a part of the ownership, because if you are able to say that this is what I find works best for me, I respond in this way. If I do this before I have my chemo, I find I feel a lot better. I manage a lot better. This is an important part of the journey, giving our clients some of the responsibility, not having them just take the burden and lay it at your feet and not be involved or engaged. Helping our clients to only seek the facts. One of the biggest challenges that we have with all healthcare matters is so often that our patients are led to emotions and hysterics. And this may come from their support system, their environment. We serve an integral role, especially in the age of Dr. Google, to debunk the myths, to provide the facts, to help our clients make decisions based on the science and the data, not the emotions. We want to remind them to safeguard their physical well-being, to take opportunities to rest and relax, to be kind to themselves, and most of all, to be realistic with their expectations, and therefore to be patient with the goals of treatment. And finally, we always want to remind everyone that there is no good health without good mental health. So we encourage our clients at all times, whenever we have an opportunity, to invest in their own mental health. Thank you so very much.
Mrs. Rose, thank you so much. You're getting some hearts there. It's lovely to hear you speak about this aspect. And I must say, Dr. Ononuju must have had a good idea to invite me to chair today's session, because these really are areas that I myself am very passionate about. How do you manage the quality of life and support your patients beyond the actual physical ailment that they must be going through? Because more and more, I think mental health is a concern, even in your non-ill population, much less in someone who is battling an acute or a long-term illness. Thank you so very much. I'm sure you'll have many questions and comments and need for discussion. So please do. I hope you can stay back with us, Mrs. Rose, for the rest of the session.
I am going to step away and come back, Professor Asnani, because I'm in another presentation also.
Oh, thank you.
Yes, so I'll come right back. Thank you so much.
Multitasking to the max. I invite all of us, and can you imagine, it's almost 250 or 50 of us on the call today, on the webinar today. Do remember your questions, and if you wish, put them in the Q&A section of our webinar, so that we can get going with some good conversation at the end of our formal presentations. So let's move right along to, not to say the best for last, because we've had two excellent presentations. So I want to know how Dr. Frankson is going to beat this, and I have no doubt that he will be equally scintillating. Dr. Anthony Frankson, Tony Frankson, he'll be speaking to us on ethical considerations in the management of female cancer patients. For those of you who might not know Dr. Tony Frankson, he's a lecturer in epidemiology, biostatistics, and bioethics. Ethical stakeholder involvement in a personalized manner, whether in promoting wellness or in actualizing community-oriented medical education and research, has been a persistent passion of Dr. Tony Frankson. His career commenced in the year 1977, and since then he has practiced as a physician, as a public health professional, and more recently as an academician, a graduate of both the University of the West Indies and Loma Linda University. Dr. Frankson has served as a hospital-based medical officer with Jamaica's Ministry of Health, the medical officer of health with a USAID-funded community-oriented primary health care project, delivered intensively over a 6-year period in Frenchtown, Jamaica, by the Adventist Development and Relief Agency as both a university-based and private evaluation researcher in California, assessing several federal grant-funded health-related projects in California, USA. He's worked as the coordinator of the Youth Development and Teen Pregnancy Reduction Project of the Riverside San Bernardino County's Indian Health Services in California, USA, as the chief medical officer within the Ministry of Health of the government of Turks and Caicos. Wow. For the past 13 years, though, his salutary contribution has been as an academician bolstering clinical research, employing participatory, empowering approaches with medical professionals and related graduate as well as undergraduate students located at both Mona, Jamaica and Nassau, Bahamas campuses of the University of the West Indies. Over that period, he has co-supervised the research of over 100 research projects executed with collaborating academic stakeholders and has relentlessly tackled related challenges, including improving peer-reviewed dissemination of findings. You know, that is such a gap sometimes, and Dr. Frankson has been working hard on that. He retired from the university formally since August 2023, and his present employment is back in Jamaica with Northern Caribbean University in Jamaica, where he's presently the campus physician for that university and the director of their research and statistics, including being chairperson for their institution review board, their IRB body. Currently, he also serves the wider Caribbean as the president of the Bioethics Society of the English-speaking Caribbean. Additionally, he serves in Jamaica as the chairperson for the National Mirror Committee of the Bureau of Standards of Jamaica. So, wow. Dr. Frankson, I don't know how you do all of this, and there's so much more to say about you. I'm positive, but I'm going to hand over to you, and he's going to be wearing his bioethicist hat for us this evening and speak to us on ethical considerations in the management of the female cancer patient. Over to you.
Thank you, thank you, thank you. I hope you can hear me.
We can.
Okay. Well, thanks for that mouthful of an introduction. I've been working hard for almost 50 years. So that's how you fit it all in. And try to be living healthily as well. But, you know, aging considerations are always a challenge. However, it's my pleasure to be here, and I want to thank the college for inviting me. And I hope that we will have an interesting session after this. Professor Adnani, I have no wish to compete with those two excellent presentations. I will just merely compliment them because I'm really at heart a collaborator. I work best in collaborative teams. So if you view that way this evening, everybody, you would have gotten Easter bun and cheese, as well as your veggies and your proteins and everything else, and you would have left blessed. I have no serious conflicts of interest. However, you heard that I'm with the Bioethics Society of the English-speaking Caribbean, and we're looking for new members. So please go to the website you see there, bioethicscarib.org, and also get involved with us so that we can get you on our list and include you. Our annual general meeting is coming up in June of 2024. It will be by Zoom, so it will be easy for you. As far as my spiritual persuasions are concerned, I'm an ardent apologist. I will argue for a spiritual point using the best theological and philosophical and also practical and experiential arguments that I can, in the hopes of persuading you in the way I see the world. And that it's a beautiful way, so I always am anxious to do that. Luke is a physician. He's a Hippocratic physician. We call him Saint Luke now because he's marvelously written so much of the New Testament. But he tells us of a story of an ill woman. And for 12 years, she had a flow of blood. I don't know. Histology was not developed yet, so we don't know whether it was a cancer, but let's assume it was. The verse tells us, though, that it depleted her livelihood, and she spent all her means on a physician, and her pathosis persisted. Well, help was coming through in the form of the renowned healer, who had quite a reputation, Jesus Christ, and a crowd thronged him, and she pressed forward and cautiously and trustingly touched the hem of his garment. And immediately we were told by the doctor that there was cessation of her flow of blood. That no doubt is beneficence. And her accessing the health care that was available by the healthcare wanting to walk in the direction of her, and maybe she also seeking him out, is an outplay of justice. Well, the healer engaged as researcher and said, "Who touched me?" Even though all others else, we told in Luke 8, verse 45, denied that anyone would touch him. And in fact, how incredulous it would be that he would perceive that anyone touched him in such a throng, surrounding him and pressing so hard on him. Well, he's the ultimate evidence-based healer. He perceived power, otherwise known as virtue, transmitting out to one in need. And as such, he's both a caregiver and a seeker of evidence, seeker of things that he's uncertain about, and doing it in a very passionate and immediate and timely and systematic way. How he does it is the way that he treated the woman at the well as well. It's the way that he treated others, his friends, when their brother died, etc. It was always with compassion. And that consistency spoke a lot about his character as a great healer, a great medic, and more, a teacher even. Well, the woman is overwhelmed when that question is posed. And she's hiding and trembling as evidence of that. But there it is, she's identified. But she chooses to make the decision to declare and to give the data. So she declares in her history that she was the one and that she had been bleeding for so long, and that the experience of getting to touch the healer brought immediate healing. Well, the healer's non-maleficence was such that he turned around and said to her, "Daughter, be of good cheer. Your faith has made you well. Go in peace." I can just see the awestruck, what was a mob, now a worshipful group. You know, too often well-meaning caregivers are heard to say what is said in Luke chapter 8, verse 49. Do not trouble the teacher. Don't trouble the healer. You know, don't go anymore. Don't seek the help that you need, etc. Well, Jesus, upon hearing it, provided his holistic care by saying, "Do not be afraid, only believe, and she shall be made well." Well, it actually said he shall be made well, but we're dealing with gynecology this evening, so it's she shall be made well. And this time it was an assumedly deceased daughter of Jairus. Actually said that too as well. And both stories are sandwiched around each other. And Jairus himself was a ruler in the synagogue, which means if you understand Deuteronomy 24, verse 8, which says, for example, take heed in an outbreak of leprosy, that you carefully observe and do according to all that the priests, the Levites, shall teach you, just as I commanded them, so you shall be careful to do. It showed that the priests were actually the doctors, and they actually were the teachers. It is we in modern society that tease these apart artificially. But only when we practice, we realize that as we care for people, we are both priest and doctor, and yea, even teacher. In fact, the word doctor in Latin is actually what the word teacher means. Well, the word, yeah. And there it is, Luke 8:41 to 42 is where you find that bit of evidence. Well, we're talking this evening about ethics. So it would be not good if I left out the golden rule. I'm going to amplify it though. Matthew 7 and verse 12. Therefore, all things whatsoever ye would that women should do to you, do ye even so to them. For this is the law and the writings of the prophets. That's the golden rule. Every ethical canon has that particular virtue in it, that particular admonition in it. It's about ethics. Can you mute your mic there, Dr. Levy? Okay, thank you so much. It's about ethics, but we must mention the law as well. The law is a kind of a crude attempt at ethics. One that sometimes works and sometimes doesn't, because it has one thing about it that is stronger than ethics in the relationships that it tries to govern in societies and protect. It makes the creeds, the codes around them be enforceable, so that society has to do those things or else they would have broken the law. And there are consequences for that. Some of those end up being quite ethical, some of those laws. Like the law against murder, very ethical, while others can be unethical, like a law that has passed its time, like we see happening right now in Arizona, with even people of both parties backpedaling and trying to get rid of an ancient law in order to address the issue of abortion more up-to-date, in a more up-to-date way. We have all kinds of laws, common law, civil law, criminal law, etc. But we won't get into all of that this evening, just to let you know that the law is actually the next level. In fact, I'd call it the next level down in trying to get relationships established. And it's important to adhere to them. We're told as good Christians that we should honor government, obey, etc., as long as it is proper in God's sight. Alexander Solzhenitsyn had this to say about the law. It's the minimum moral standard of our society. So if you're basing your actions just on the fact that it is legal or illegal, you're really operating at the bottom of the barrel of morality. Ethics, on the other hand, is more of a set of covenants that we have with people. And it has been a fascinating aspect of philosophy. Philosophy itself has maybe 4 areas, major areas. There is metaphysics, where we wrestle with reality, and then included in it ontology of who is God, etc., etc. And then we wrestle also with epistemology, the Greek word for knowledge. How do you know? What do you know? Etc. At this time of the year, we have great epistemologists on our campuses. They're called students preparing for exams. They need to know what to know, how to know, which one not to know, and so forth, so they could pass and be certified. And patients too need to know, and doctors need to know what to impart to persons without lying to them, etc., and by being sufficient, etc. That branch of philosophy, epistemology, helps us in that regard. We call it in Latin, we call it scientia, from which we get the word science. So all the word science really means is to know. And it doesn't have anything to do with it being an experiment or not. It means to know by whatever good means. But we have narrowed down the word science today. And then there is logic, the rules by which you argue. And of course, there is the values theory part under which ethics falls. And ethics itself has 4 major categories. Descriptive, where we do sociological comparisons, for example, and what is it that is actually being done? Is it that, are people really that callous and indifferent to the rising crime rate or to the conditions under which people get health care, etc.? What is it that is being done? Is that what is happening? Is that excellent care being given in this area or that? Is there a great emphasis on wellness or is there none, etc.? That aspect of ethics will be what we call descriptive ethics. And then there is normative ethics, where we have prescriptive rules generally and also specifically. These are our oughts. You ought to do this and you ought to do that. And this is my justification for doing this, is that so and so and so on. So you make premises and you come to a conclusion that looks like it's a good justification. What are the cultural norms, and are we abiding by those cultural norms? And really, what is correctness? What is correctness? I want to let you know that you will be amazed to see how around the world, most cultures pretty much value most of the same things as the correct things to do. Ethics is one of those things that really there is a lot of harmony around the world as far as cultures are concerned. Maybe in other aspects of our professional lives, we have sometimes quite great disparities, but the debates actually amazingly end up proving that a lot of us as human beings, whether we're from the east, the west, the north, or the south, look upon the cultural norms a lot and the oughts a lot in very much the same way with regards to the correctness about them. Then there is meta-ethics. It's more analytic. We're getting into the epistemology now, breaking down what does the word ethic mean? What does the word correct mean? What does the word right mean? What does the word just mean? You know, good. What is good? Etc. And it's itself a lively area of philosophy. All of those 3 areas are not really the primary purview of us as physicians. Our area that we really flourish in is especially this next area, which is the areatic or the resultant virtues area. And we either go about it looking at, so in the end, what will we get if we do so and so? Will we get a decrease in the birth rate, will the mortality rate, the survival rate go down, etc.? Will satisfaction go up, etc.? That kind of, when we look at the tail or the telos, to say the Latin of it, that kind of approach, a utilitarian approach, where we have utility values attached to certain things, is known in the world of philosophy, etc., as the teleological approach. Whereas there are those who say, you know, there are certain rules that we must follow, duties that we must do, etc. And if to be a virtuous person, you must be found to be faithful. You must be a good steward. And that's the more deontological view. Then there's also a relativistic culture-based view as well that is coming up in the more recent aspects of the development of ethics as it is applied in an arithmetic format. And then we say make it relative to our cultures, etc. And then enters moral subjectivism. What were your motivations? What were your intentions when you did that? And we talk about your character. whether you were a good person, you know, you went into medicine. Did you go into medicine for money, or did you go into medicine for an altruistic reason of making mankind whole? And oftentimes there's a mixture in there because none of us are perfect and we are on the pathway towards that by the grace of God. And, you know, we look at compliance with the culture, compliance not only with our culture here, but the culture that we hope for the future, including the culture that we hope will be, if there is eternal life, what will eternal life be like? Can we aspire to that from now and start behaving like that? So core principles are to be adhered to and valued, and consequences of that are to be paid attention to. The view that I prescribe to myself is a transcendental virtue-based ethics approach. I like Psalm 41 verses 12 to 13. As for me, you uphold me in my integrity and set me before your face forever. Blessed be the Lord from everlasting to everlasting. Amen and amen. Psalm 41 verses 12 and 13. Well, a virtue-based approach would make us look at primary care, for example, as the way to approach the best manner in which to deal with female cancers, among other diseases. And I've taken this, somebody has their mic open, so just be careful to mute your mic. So a primary care approach is what the World Health Organization would ascribe to as the approach that is where we begin when we deal with female cancers, when we deal with diabetes, when we deal with many chronic non-communicable diseases, in fact, infectious diseases, etc. The more common diseases is really what primary care is about. It's not about the simplest diseases, it's about the more common diseases, because nobody gets trained for the length of time that a doctor gets trained, and it can be ethically relegated to, oh, you're a primary care doctor, you only look at simple things. That's very insulting and it's very inappropriate. You look at the more common things just as rigorously as the specialist would look at it. But in that case, you kind of assume a specialist role because you're a specialist of the common things that you see. It's a less formally prescribed set of things. It's more nebulous. So what you specialize in as a primary care doctor, the primary things based upon the communities that you are in, could be quite different from the ones down in another parish or another island, another country, etc. So that's the nebulous nature of it. But it certainly turns you into a specialist of sorts. What I like to do is to say, in the end, when you put all those together, those primary care personnel together, they're really extensivists, more than even specialists as they work together. I always remember, you know, when I was on the Mona campus, when I would go to the health service, one of my classmates was the ophthalmologist there who fell in love with primary care and worked there as a primary care physician, and she saw primary care patients. But every single one of those other physicians, primary care, would refer the eye patients to her in her role as a primary care, knowing very fully well that this is an area that she's even more comfortable with than they were. And she would do the same for them in other areas. So there's that harmonious thing there that is really very nice and flexible and can make medicine very personalized. And so, no wonder the World Health Organization wants us to put at the center primary care, where there's continuous, comprehensive, person-centered care, and all of the other things, social service, liaison with community health workers, etc. All of that happening, ministering to the community, whether it is with a female cancer or non-cancer or whatever. And then being well supported by the other wonderful areas, from women's shelters right through to maternity and emergency medicine, community mental health, the laboratory diagnostic things, etc., environmental lab, etc. This is the picture that the World Health Organization is putting that we should be using to deal with primary care. And an archaic view of ethics would say this is a very virtuous way to look at it. In fact, I think the folks in the World Health Organization even go even further and discourage people doing private practice. And you don't have to take my word for it, just read their own writings. They discourage private practice to the extent that they're encouraging people to team up with for the greater good of the community, the more utilitarian kind of view, and really see this thing going, because this model is not catching on as it should. And it probably is also contributing to some of the reasons why some of our cancers turn up late and get referred to specialists late, etc. Because the relationship that it would foster is not there, and the network that it provides is defective. So you will hear of this going on for the future. I don't have any problems with private practice with people. I love people doing private practice, so I have a difference between that and the World Health Organization. And I would just encourage private practice people to make sure that the primary care needs of your community where you are earning a decent living are also well supported, whether you do it voluntarily or whether you also do it for cash, because the good book says that, you know, a workman should be hired, which is worthy of his hire, etc., etc. And that money answereth all things, all in context. Well, what we hope to get from a system like that is increased satisfaction with services, better compliance rates, less use of specialists and emergency services, fewer consultations, specialists, more efficient resources and services, better understanding of the psychological effects of a person's problem, better uptake of preventative care by adolescents, protection against over-treatment. And really, we're really pointing to is that philosophy is important. The branch of philosophy that is called ethics is important. It helps to guide our consciences. Socrates would tell us that the unexamined life is not worth living. So here is a wonderful way to examine your life, use principles of ethics and tie it in beautifully with your principles of your spiritual insights and growth, etc. What we do in medicine is not, as I said, really that much of the pure ethics. What we do is applied ethics, which is really, it can happen not only in medicine, but also in business and law and commerce, etc. And it's really a branch of sociology, if we are to be truthful. But then so is medicine, according to Professor George Lane. Professor George Lane says in his book that medicine is really a social science. Very interesting, and as I have practiced, I really have to agree with him. It's really about people and their betterment. And we press on, but we borrow from the philosophy, we borrow from ethics, we borrow from all kinds of things to make what we call in our area biostatistics. Morality and ethics are very closely akin, and we use them systematically through sound arguments to address the content, the epistemological side of things, of what is right versus wrong, bad versus good, regarding making distinctions in life's vital issues. For example, a question could be asked, what would be a good cancer prevention system for women residing here in the Caribbean? And that's the what question. Definitely we're doing philosophy here. And then we move to the why question, which is the favorite three-letter word of philosophers. Why is it that oftentimes in our region, women present quite late with uterine cancer? Those are some of the things that makes it something that is inescapable. We find ourselves asking these things and taking the time to school ourselves in ethics helps us to see that it is a responsible thing to do and that there is actually a very proficient way to do it. That's an artful reasoning process of argumentation regarding determining what is right versus what is wrong and so on. Really what we are as physicians is practitioners of technique iatrike. Technological iatrike, healing of persons, etc. by us, yourselves. And even the word iatrogenic comes from that as well. So medicine is neither solely a science nor solely an art, but an applied blend over time using judgment, causality, and so on. Casuistically, I should say. And that's like by using a case-by-case approach. And we use virtue theory, we use principalism, we use ethic of care and casuistry. And with virtue theory, I mentioned a few aspects of it, or honesty, etc., fidelity, etc. Principalism, we actually know that one from many of such like presentations where we talk about respect for authority, of autonomy, beneficence, non-maleficence, justice. The nurses even take it further and talk about fidelity and truth-telling, veracity, and so forth. But we kind of fit those things that the nurses take further right up into respect for autonomy. But ethic of care is a very interesting thing that we actually use when we have a patient or a group of patients or a particular condition. If we are at the level of, say, the Ministry of Health that we need to make a difference with, and what is the right way to go about it? What should be done first, etc. How will our society grow when we have gone through? How will our patients grow? How will our patients be made more whole as we do that? And casuistry is actually looking at the same things like autonomy and so forth, but being more flexible and more traditional with it. And we look at not just what is the right respect for autonomy at the moment, what is the beneficent thing at the moment, or the non-maleficent thing at the moment, or the justice thing at the moment. But we look at it as what is different about this case? And that's why we call it casuistry. What is different about this case? What is unique about this case that we now have to apply with intelligence, with good philosophical reasoning, those 4 principles? And in fact, was there a case like this last year in Trelawney, or in Georgetown, or in Port-au-Prince, or in Port of Spain, etc.? Was there a case like that? How did they handle it? Maybe that is the way we should be handling it as well. If we tried that way, what would be the consequences? And that's a case-by-case approach. You don't find us using that very much in public health, but actually you find us using that a lot in our patient care. We use philosophy and we come up with those things that I just talked about. But a good use of philosophy has left us with also 4 goals of medicine. The first goal is to relieve symptoms. And of course, the best way to relieve a symptom is to prevent it in the first place. The second goal is to cure disease. The third is to prolong life. And the fourth is to improve the quality of life. And, we use that in we strive at that in ways that lead us towards making decisions that make those things happen. And here are 7 steps that can help you towards making the right decisions so that you can fulfill those goals while being adherent to good ethics and, in fact, good philosophy in general. Number 1, gather the facts. What are the relevant details of the scenario, whether positive or negative? For example, a person might have some kind of small cell ovarian cancer, etc. Maybe it's a hereditary cancer. And the doctor is a woman whose daughter is also an adult. And the doctor is anxious to say, can I disclose this to your daughter? Because this has a familial tendency to it. There's a bit of inheritance that is one must pay attention to, the heritability. And if the woman says, yes, sure, then those are facts that we can really be happy with. The doctor feels relieved, they can communicate this, they think they have fulfilled their clinical duties as well as their public health duty maybe. But if the woman says, no, I don't want my daughter to know about this. She and I actually are not speaking for the last 2 years, and we just started to speak again. I don't want her to hear anything bad about me right now, etc. Those are the same issues medically, I mean, pathologically, but they're quite different sociologically. And in fact, now ethics comes in and says, what should the doctor do? What is the good thing for the doctor to do, etc. She can't coerce, or she should not, etc. And I'm assuming it's a female doctor. And I take the liberty of that because most of our graduates are female. So the odds are in that favor. She's in what is called an ethical dilemma. She has to sort out something that maintains relationships and does as little harm as possible. And in the end, there can be the best outcome. So the only way you can get at that is by looking at the relevant details, asking even more questions about the relationships, the breakdown of the relationships, etc., etc. And as you get the facts, you are in a better position to introduce virtue or to have power come from you, like that woman who touched the hem of Christ. Getting the facts are important. Here's a nice way to do it. Write down the scenario, and you can do that in the blank section on the right. In fact, if you have a book like this that we use with our medical students, our great Professor Walren's book, Ethical Practice in Everyday Health. What a lovely book. What a lovely man. He was one of my best surgery teachers. And a surgeon who took the time to move beyond just the philosophy, etc., to apply it and bring it home. He actually talks about us having, treating it. He has many scenarios at the end of each chapter of his book, of his various chapters of his wonderful book that we use so faithfully with our undergraduate medical students. And I hope we don't change in any time soon, although there are other excellent books out there. But one of the things that he does quite well is he outlines scenarios, and he comes up with funny names for some of the characters in the scenarios. It helps to maintain anonymity and so forth, but it also helps to liven up the reading. And then the exercise is to ask the students and each of us as ethicists, when we're in those situations, to tease out which parts in that scenario showed that there was good respect for autonomy, which parts showed that there was a breach of respect for autonomy, which parts in that scenario showed beneficence, which part showed a lack of that. And the same goes for non-maleficence and justice. And really, this is an empowering thing to do if you want to get to the point where you can make a decision and come out of an ethical dilemma. Number 2, determine the ethical issues: justice, beneficence, non-maleficence, respect for autonomy. Which are the rights and your duties? What are your rights? What are the person's rights? What are your duties? What is a person's duty in taking care of themselves and in relating to your service that you're offering them? The issue of consent, the issue of confidentiality, privacy, anonymity, etc. Looking at risks, minimal risks, or is it moderate risk or severe risk I'm dealing with, and weighing it against benefits and the effect of those benefits. If it's a small benefit, is of practical significance, that benefit. And as you look at respect for autonomy, The informed consent that I mentioned earlier involves implied consent. So when a person walks into your office, you have every right to start managing that person by just saying, and what are you here for today? After you have, of course, greeted them. You're not being intrusive. Why else would they be there? Your shingle is out, the sign is there, it says Dr. So-and-so. It doesn't say carnival, or it doesn't say what something else. It says, I've come to the doctor. So just by stepping in, you have given a certain amount of consent already to be interfaced with. But we must respect it. And even though it's implied, it must not be done in a crass way, but in an inviting way. And it has its limitations. It doesn't mean that you can now launch the person off to take blood from them or to take them to surgery, or etc., or even to examine them. You now have to go and seek verbal consent as the next phase. And that's a little stronger because communication happened, brains were engaged, and contracts are being instantly developed. And of course, there is the even more solid one, which is written consent. And that is the form that we really hope we have. And if as time permits, etc., and we should make time where it's necessary to make sure that that one is in place, because in a court of law, that stands up the best. But more than a court of law, in the relationship between the doctor and the patient, that is the most persuasive one, if there are, in fact, misunderstandings, or if there are things that we need to do to promote compliance and so forth. The person who chooses to be coming to us is a moral agent, but we are also moral agents because we choose to offer a service, and we choose to have that service be one that is ethical, so that there is a consent process, for example. You might remember the old history way back there in Johns Hopkins involving Dr. Southam, that had him being one of the noted, brilliant people of the early 1900s. And he took it upon himself to start injecting in small doses cancer cells into people and give them very shabby consents. You may want to go and research that and look at the history of that. You will be appalled to see what was permitted. And it actually happened in a Jewish hospital just shortly after World War II. And, you know, with no consent, he thought he was justified because he said, actually, I'm giving them cancer cells from somebody else, so the HLA complex will destroy it anyway. I just wanted to establish that if I do that, it will actually boost their immune system so that they will be now resistant to cancers in the future, etc. Misguided altruism. And thank God for peers. His peers, many of them complied, but many of them actually resisted. And eventually, the matter went to court, and he went to the medical council, and he was stripped of his license for, I think, 2 to 3 years. And then he came back and assumed his illustrious practice and his interest in cancer, and became actually the first president of the American Cancer Society. So the history of medicine is a most amazing thing. But, you know, we needed something strong, and the Nuremberg Code came in time. And it says the voluntary consent of a human subject is absolutely essential. This means that the person involved should have legal capacity to give consent, should be so situated as to be able to exercise free choice, without the intervention of any elements of force, fraud, deceit, duress, overreaching, or other ulterior forms of constraint or coercion, and should have a sufficient knowledge and comprehension of the elements of the subject matter involved as to enable him to make an understanding and enlightened decision. And you can read the rest of it. Actually, Professor Walron's book has it there in one of the key chapters on ethics and research. And it has several other sections to that code that you should never deprive yourself of, but you should make yourself educated about. Another great product of sound reasoning is not only have we come up with the fact that you must gather facts and you must pay attention to principles, but another sound principle is that came from philosophy that helps us in ethics is patients are particularly vulnerable. And so as a result of that, we have another sound set of products reasoned out as well, called the Patient's Bill of Rights. Decisions of a competent adult patient supersede the opinion of the physicians, etc. Usually, unless there are significant public health implications, of course. And the consent topic is something that I must make sure that we leave here clear about as I move to the next things. So the last things I want to say about the consent issue is, when you're doing consent, have description of the procedure or the treatment in a way that is to the level of the person, but it must be complete. Explanation of the risks and the benefits helps that completion to happen, that completeness to happen. For it to be complete, and to be just, etc., it must also include a description of alternative treatments. And there must be a description of anticipated outcomes if no treatment is given. And description of anticipated short-term consequences of treatments, including length and challenges of recuperation and short-term side effects, etc., and long-term benefits and maybe long-term side effects if the research into that is available. And the description of antecedent long-term consequences of treatment, including permanent alterations to the body that may occur. All of those things are things that come in when we're dealing with cancers of the female. We just heard our first presenter talk about the fact that sometimes there are problems even after newer techniques in handling the cervix, cancers of the cervix, and that the results, 70% turns out fantastic, but we have to watch for that 30% who may have to go and do other things. All of those things need to be explained to the persons that are involved. Another thing that we mentioned above that I'd like to say a word on is justice. Justice is access to care, that it must be fair. If you are in need of it, your situation of economics or demographics or your geography, etc., your political persuasion, sociology, and so your religion and all of that should not be a barrier. You should the medicine, in the art of medicine, and that is a science as well, we always find ways or seek to find ways to circumvent such things so that we can actually say justice prevailed in this situation and the person's getting it. Is the world fair? No. But do we strive towards it? Yes. And access to legal resolution is also included in the issue of justice, even though that's not the primary meaning of it when we say justice. But that is included as well, because you have a right to seek legal aid and to resolve breaches in relationships. And that should be maintained. So those are 2 of the 7 things. Number 3, determine what virtues and principles have a bearing on the case. So after you have made a list of the scenario and what the benefits and so forth, then now you go and do an analytic process and say, what are the things that are breaching virtue here, etc. And we need to pay attention to case by case, like a casuistic approach. Number 4, take time to list the alternatives. And that will also complement what you have to cover to explain in the consent process as well. But now you're trying to sift through a problem, a dilemma. So you haven't probably reached the stage of consenting yet, but you're now just trying to make sense of a dilemma so you could resolve it. Even there, you should list the alternatives, because in doing that, you actually can see sometimes things that you would have normally overlooked, because every one of us has biases and we have a preference, some of us for chemotherapy, some of us have a prevalence for surgery, some have a prevalence for natural medicine, etc., etc. We should look at the alternatives and of course compare those with the virtues and principles because in that way, we are actually looking at a holistic approach to the whole thing. And as you do that, consider the consequences. You want to treat a cancer patient, what are the reproductive consequences of it if she's of childbearing age? What are the risks, the benefits? And in the treatment, if the risks have been realized as what we call adverse events, are they minor? Are they minimal risks, such as a little amount of extra than you had expected of bleeding, but it's resolved, etc.? Or is it more so one that is moderate risk? You know, a minimal risk is risk that is around what you do on the everyday walking through life. That's everything you do right now, sitting on that chair that you're sitting on, it could collapse, but it won't, because the probability is that you bought well, and it's going to keep you up right until the end of this lecture, I hope, and many other times before. But it could happen. It's a risk. And there are other things, but they're so rare, etc., that you call them minimal risks. But the moderate risks are the ones that are not so rare, and they actually have some significance clinically, etc., and even socially. And then you have things that you can do to address them. The compensatory interventions are like counseling, or like giving the right amount of blood transfusions, etc., etc. They're there. You know, transplants might be available, and so on and so forth. And then there are the severe risks. And that also is probably when it depends on how extensive the transplant is and so forth. But there are other things for severe risks that you deal with when you are dealing with cancer, like those wonderful drugs that end with MAB, and the other wonderful things that we had before that, that have a tendency to have their own risk of affecting mortality. But their benefits, we hope, are greater than their risks. And so we still prescribe them to terminal patients, for example, and know that that's the best we could do to maybe provide a few extra months, etc., that the person can fix up their affairs, and so on and so forth. And then, having done that all, make a decision. The Bible says, don't be a double-minded person. You have thought through things, etc. Let the most important and logical thing be the thing that you now carry out, and make a decision and move forward. To deny doing that is actually unethical, because actually you are vacillating and you are putting persons who are vulnerable at risk in ways that maybe are unnecessary. Now, how could we give a lecture like this without talking a little bit about our research and what that is as well? We involve our female patients in research. And we have to say that George Gett, in his eagerness to study cell lines, looking in immortal cell lines, he identified a set that came from Henrietta Lacks, who was born in August of 1920 and died in 1951, just 1 year before I was born. And we know the story well, so I will not give you the details of the Hella cell line, as an abbreviation of her name that honors it. And it was vigorously researched from 1951 to 1966. And then it was declared that this was the only immortal cell line that was found. And it actually chilled, because everybody was looking for immortal cell lines in other sources, but this was the one that prevailed. Sadly, no consent has ever been gotten from to use her tissue to do what it has done, and no compensation to this date has ever been offered. And the family was made aware in 1975, but still arguing about things. And this has made medical history, though, to the point where every lab so many labs across the world now have extensions of this cell line, that if you put them together, you would actually get tons of, maybe 30 tons of cells from this one lady's contribution to this date. And if you were to line them up cell by cell, they would actually stretch around the equator three or more times. so important it is. And unfortunately, we could have done far better ethical jobs in getting us to where we are now with this, but we are so grateful for what we have learned using that. As you began this evening, you heard that the big cancers that we would focus on are breast, uterine, cervix, uterine body, fundus, ovarian, vaginal, or vulva, and oviducts and fallopian tubes. Very rare cancers, I understand, but I had to include them too, because they too must be attended to in the same ethical way and with the same rigor of care that our previous presenters have outlined, whether it's psychological or whether it is obstetrical and gynecological. Clinical considerations that I would like to for you to bear in mind are that there is still a problem with late presentation of a lot of our things or female cancers. And the future course depends on whether we use a monistic or pluralistic worldview in adopting it, how we go forward, because the World Health Organization would like us to do, as I said earlier on, a more comprehensive approach that really helps to drive down the numbers so that, and helps to increase awareness so that more readily we see women presenting with the various cancers, if at all, if we fail to prevent them. If we fail to prevent them, then we would love to see them presenting to us much earlier. My experience with gynecological oncologists have oftentimes been a sad one, because I have had to be cheering them up, because when they come to look at their data, which they bring to me to analyze, is the depression that the persons who have come so late have such bad outcomes. And we need to make that a clinical consideration of great significance, as also we make it a public health consideration as well. We need to adopt, if we need to, AI or epidemiological's latest techniques, etc. We need to adopt digital interfaces of other kinds to get our women to come in earlier, because the results that I saw from the first presenter, for those who came in earlier, just speaks for itself. We're talking about massive 70–80% survival and so forth. That's what you want. Some female cancers, all things considered, are aggressive, and no patient should be abandoned and told, oh, there's nothing more we can do for you. We have reached a better stage now than that. And we must remember that we are not perfect yet to know how to remove things completely. So recurrences are something that we will be dealing with for a while, although there are encouraging progressive technological developments that are happening. Let's see where that goes. It's very exciting to see some of those. And there are those who we must face our end-of-life situations, and we have to do the end-of-life death considerations, preparing persons to face it prematurely and to interface with palliation, and the rest of what goes in planning and handing over to your loved ones in a way that really bespeaks the fourth kind of prevention, which is, if people have to die, let them die with dignity. Young females are not exempt, and I mentioned one in the scenario that I gave. And then we have some who are minors, and that means that they are below the age of consent, and as such, they do not have social capacity, and therefore, all should be done to approach them too with all the principles, and also casuistically as well, case by case, as we look at that, and from country to country, because some countries might have liberated minor issues that are worked out, and some might not, and those should be made familiar and dealt with. Fertility issues may be involved, and its preservation in adolescence. Adoption may be having to be considered, complicated by chemotherapy or other therapies of significance. And some pregnancy loss might occur during drugs that we
Doc,
may
sorry
want
to
to.
interrupt. 1
Oh.
minute.
Okay, let's make this a prophetic minute. Some pregnancy loss drugs may be needed to cause our resolution of the problems, but we may have an increase in cancers of the offspring. Right, you might be treating a pregnant woman. The placenta is excellent, but not perfectly excellent, and they will have drugs sometimes percolating over. Sometimes surgical interventions and side effects for treatment and prevention can be life-altering. And another clinical consideration is disclosing inherited diseases that were mentioned, by our first presenter. HIV as vaccines are some things that we celebrate medical triumphs about if and when they do happen. But resistances are things that sometimes complicate these because it increases the chance of cancers of various areas, including female cancers. Active research into novel prevention and treatment possibilities is going on and must be balanced against present standard of care. And physician-patient interactions must be paid attention to because they're stressful emotional events, and maintaining confidentiality is paramount throughout. The role of breast and fallopian tubes in cancer as cancer epicenters need to be considered as we look at whether we should also be introducing salpingectomies and mastectomies prophylactically in higher, what are the higher risk things that relate to that. We have all kinds of wonderful things that we can do: prophylactic surgeries, medications, menopause issues, quality of life. As we introduce menopause, we might be introducing medications to alter it that actually are themselves addictive, like venlafaxine. And some people will want to not live with that for the rest of their life, but actually will want to wean themselves off of it. That too is a right, and there are ethical ways that it should be done, and prevention. Well, I could tell you a lot more about the cancers, but you can know that by, I will just say this one thing. We are now learning that cancers are not just genetic disorders, etc. They are disorders of pattern recognition. There are those who are looking to use some of the various chemicals that we use, such as amlodipine, felodipine, etc., that you see listed here as electroceuticals is the name that they're using to as adjunct therapy, etc. And there are those who are looking at cancers as places where the female cancers, for example, as diseases that are not just genetic diseases, but also disorders of pattern recognition, and bioelectric patterns are being employed at places like Tufts University to induce reprogramming of cancer cells, much like your teenager. If your teenager goes bad, you don't kick them out of the house, you rehabilitate them, and you hope that they will become adults that are wonderful members of the household going forward. And we have Michael Levin from Tufts University. I encourage you to look at his work, fascinating work, as he looks at modifying the bioelectric software that runs the tissue hardware so that you actually can control growth and patterns without genomic editing. And the future looks bright. We have optical non-invasive approaches, looking at normalizing cells, immunotherapy. Anna Olivia Headley, who died at 9 years old, started a movement that actually Linda Malkus at City of Hope is working on. Big news last year, AOH 1996 in honor of Anna, is a small molecule targeting of transcription replication conflict for selective chemotherapy, PCNA inhibitors is where it works at, that actually quite cutely prevents the cancer cells specifically from reproducing and preserves normal cells with no discernible side effects. And it's orally administered as 2 tablets, 1 in the morning, 1 in the evening. It's, of course, now just getting into clinical trials. Let's hope that it becomes a part of the answer and maybe at least a complement to other things, but also maybe even the answer. It's 70 cancers that it has in the animal studies shown to completely cure in animal studies. The electric fields, etc., better prevention and so on. Many, many things exist that ethically you have to hold on to and pay attention to, keep abreast of, because they must now be included in the armamentarium as we go forward. I like this quote from William James, which says, intelligence is the ability to get the same goal using different approaches. Well, my time has run out, but I want us to know that there's a public health aspect to this as well. And I'll just mention it involves community versus individual risk. It involves individual liberty versus community health. And it involves allocating of resources, individual versus community priorities. And it involves community action with counterproductive effects and unintended consequences. If time permits during the question and answer, and a question comes there, I could expand on that. But my parting slide is Tedros Adhanom Ghebreyesus, Director of the World Health Organization at present, in the 76th World Health Assembly, pointed out 5 things that we must uphold, and ethics upholds these: promoting for health, providing for health, protecting for health, powering as virtue-based approaches for health, performing for health. Thank you.
Wow. Dr. Frankson, I should have expected this kind of a presentation in your typically very unique style. Doesn't even make sense, typical and unique. Those who know you should have expected this. Thank you for your excellent presentation. Sorry that it is this late and we had to kind of try to come to an end, since we do hope to finish by 9, but thank you for your unique take on how to really examine ethics and all the theory and philosophy behind how we think about good and right and just, etc. So we're gonna do a few minutes of Q&As. There is a post test that has been put in the chat and everyone can click on it and be completing it at the end. I'm sure, Sam, you're probably gonna be sending it, emailing it out to registered participants as well. But thank you. Let's go to the Q&A. Any questions for our presenters, please? There have been, while we look out for hands, Sam, will you help me out with that, please? There have been
Certainly.
some very lovely questions that have been answered, most of them for Dr. Medley so far. So I invite you to go into the Q&A area and look for the questions and the very detailed answers on that. But anyone has any live questions, we are happy to take a couple of them.
And to help, I suppose there's one question now that Dr. Medley began trying to answer.
Right.
The question is, are there any gynecological cancer screenings for girls? Dr. Medley, you want to speak on that one?
Okay, thank you. All right, so for that question, I was just actually typing the response to that one, but I'll go ahead and answer. So for girls, the only gynecological cancer that we currently have formal screening recommended for is cervical cancer, which is starting at age 21 for average risk persons. But if somebody is deemed to be high risk, for example, immunocompromised or living with HIV, then what our Ministry of Health guidelines recommend is that we start screening at the age of diagnosis. So if it is that they're HIV, living with HIV and they're under 21, then you actually would want to start screening earlier. But that's really the only case where we would recommend screening before 21. And in that case, you may screen annually instead of 3 yearly. But as it relates to the other cancers, we don't have formal screening programs or recommendations.
Okay, thank you very much. I do see one question here that you've answered. At what age should cervical cancer screening stop? And I think just for the general populace, women who have had 3 consecutive negative screens before age 65 years can stop screening at 65. They may need to continue screening beyond 65 if not adequately screened. There's no set timeline stated. Not seeing any more questions, Prof. Asnani. Perhaps the information was just so well delivered,
Yeah, yeah.
I believe.
Yes, I think some of the very, these are the questions that are there in the Q&A are some of the commonest questions that GPs will have in primary care. So, and they have been answered excellently. And we've had 3 really, really, really excellent talks, which give us the breadth of managing cancer on a whole, with highlight on the female cancers. So my own personal thanks to each one of the 3 presenters for really taking the time to prepare talks that are educating in a very lively and entertaining way as well. All 3 presenters were really engaging for me. But I won't take over what is Dane's work. I'm going to invite Dane Levy, Dr. Levy, Executive Member and Secretary of the CCFP Jamaica chapter, to bring us to a close with his vote of thanks. There, is Dane still there? Yes.
Good night, everyone. And
Hi.
thank you for allowing me to give thanks. And Monica, thank you for assisting me in the beginning of the process of giving thanks. Of course, I want to give thanks on behalf of the Caribbean College of Family Physicians who have put on this rather interesting webinar this evening, and also on behalf of our President, Dr. Seni Ananujo. We have been treated to a wide expanse of knowledge by our physicians this evening, starting with Dr. Medley and then, of course, Dr. Rose and finally, Dr. Frankston. All very, very comprehensive and informative presentations. And we are all the better for these presentations. I want to personally thank them, not only on behalf of the Caribbean College, but personally thank them because I've been reminded of a lot of facts and information that we should have at our fingertips. And of course, I have been given some new information. I want to thank them for doing this for us this evening. I think we are all the better for these presentations. Of course, we also want to thank you, Professor Asnani, for so ably moderating this webinar this evening. You have done an excellent job, and I just want to thank you as well. Thanking also our sponsors. I think it was Medimpex was our sponsor. Yes, and I want to thank them for so generously agreeing to sponsor this webinar this evening. Of course, also Sam, who is has always been with us, it seems, since COVID hit these shores. Things have been so transformed, but we have been ably guided and facilitated this evening by Sam with the work he's done on this platform this evening. Our administrative staff, headed by Mrs. Lynn Thompson Hyatt and her assistants, they did the background work in organizing it to organize the this webinar. I think our chairman or president, Dr. Senyon Onuju, she is of course to be thanked because she was instrumental in getting these presenters for us this evening. I want to thank my colleagues. At one stage, there were almost 250 of us on this platform being educated this evening. And I want to thank them for coming on this evening. I want to thank them indeed for sharing with us. I want to thank them for the support for the Caribbean College of Family Physicians. And just to put in a plug, coming up next month is World Family Doctor Day. And I want to encourage all our participants this evening, all our colleagues who are part of this webinar this evening, to join us on May 19th when we'll be having another conference, World Family Doctor Day, of course, put on not only by CCFP, but by AGP and by the Family Medicine Department at the University of the West Indies. So thanks again. I hope I've thanked everyone. But if I've missed anyone, I just want to put a blanket over everything and say thank you all. God bless you. Special thanks, of course, to once more to our presenters, Dr. Frankson. I don't know if he remembers, but when I was a little boy in the high school, he was one of my seniors, and I'm so happy to see him. Yes, I'm so happy to see him this evening. Thanks again, and God bless you all. Have a wonderful evening.
Thank you so much. Dr. Levy, good to see you. Thank you. Keep safe, everyone.
Thanks, Prof. Thanks.
For keeping it together for us. Have a good night, everyone.
Exceptional healthcare starts with delivering excellence and customer satisfaction. Medimpex Jamaica and Medimpex West Indies are today leading pharmaceutical industry players in the Caribbean region. Proudly based in Jamaica for over 40 years, we aim to improve the quality of life of West Indians. We deliver world-class healthcare products that meet the most stringent international standards of quality. With more than 350 items to choose from, our goal is to provide first-class products for healthy living.
Night, everyone. Wonderful, wonderful presentations. See you all at World Family Doctor Day, and stay safe. I think we're saying goodbye to April, so see you in May. Cheers.
Bye. Thank you.
You too.